this question. That's from November 2023. The question, a 92-year-old woman presented with complaint of lethargy, vomiting, and confusion, had history of urinary tract infection, and she was discharged 3 days ago from another hospital. History of osteoarthritis and fracture, which she had open reduction a year ago. Random blood glucose is 58 milligram per dl. Sodium is 130 millimoles per liter. Your friend doctor, a senior registrar in geriatrics, came to the ward to see another patient and approach you to say hello. The question A, what are the problems with this patient? Question B, what team will you involve in her management? Question C, what will you do when your friend came to say hello to you? This question is a recall. Most likely some student details are missed, but I go to the question. What are the problems of this patient? One, this patient is an elderly patient, geriatric patient with their peculiarity. She's likely to be a dependent. We also have she's likely to be a dependent, and their uh, medical problem and medical condition are treated with such a special group of patients. So, number two, she had hypoglycemia, random blood glucose of 58 milligrams per dl. This might be likely from loss of appetite from the ongoing acute illness, or lack of proper care, such as lack of home caregiver or geriatric care assistant to assist such group of patients. There's also electrolyte derangement, hyponatremia, sodium of 130 millimoles per liter. Normal range should be between 135 to 145 millimoles per liter. Another problem is actually confusional state because of the confusional lethargy. This could be from likely infection, urinary tract, likely sepsis. It could also be from the hyponatremia or hypoglycemia. The recent or ongoing urinary tract infection, which could be poorly treated from the hospital that is coming from, with possible sepsis. Also, I need to rule out recurrent history of urinary tract infection from urinary tract obstruction secondary to pelvic tumor, which is common in the elderly, or from renal stone. I would also like to rule out chronic kidney disease from hydronephrosis. These are possibilities as they were not mentioned in the question. Also, another problem in this patient is chronic disease, osteoarthritis, which is commoner in this age group. Pathological, he also had pathological fracture in the past, which he had open reduction from, likely from osteoporosis. These are problems in the elderly, and this osteoporosis is commoner in elderly female. This could have resulted in immobility in this patient, resulting to some of hindrance or disability to carry out day-to-day activities. I will also watch out for further complications in patients who had osteoarthritis, which could have limited our mobility. I will try to look out for deep venous thrombosis and subsequent pulmonary embolism. I also look out for acute kidney injury, which may complicate the ongoing infection or possible sepsis. I also look out for a background CKD as renal reserve are depressed or reduced as one grows older. I will look out for comorbidities in this age group, geriatric patients, such as depression, dementia, hearing loss, visual impairment from cataract or glaucoma. Though these are not mentioned in the question, but all this is to ensure holistic evaluation of this patient for holistic care. Question B, what team will you involve in our management? Management of a geriatric patient is multidisciplinary approach. involving geriatrician, physicians that are specialized in health care needs of the elderly. I also want to involve infectious disease physician, as um, infection is critical in the extreme of age in which this patient belongs to. So the infectious disease physician will take care of the urinary tract infection and the possible sepsis. I also want to involve nephrology, if the need be, for risk of acute kidney injury or background CKD in the elderly. I will involve endocrinologists to deal with the metabolic derangement, hyponatremia, and hypoglycemia. Rheumatology stroke orthopedic surgeon to address the chronic illness disease, osteoarthritis, and he had had pathologic fracture in the past, and there are risks for such. And I would like the rheumatologist to also look at the definitive cause, such as osteoporosis, and address them. Geriatric nurses for essential nursing care, geriatric care assistants to provide direct support to elderly patients, ensuring comfort and their well-being, and to also maintain cleanliness of patient home. Dietitian and nutritionalists to address malnutrition. This can promote healing and vitalize this patient. Malnutrition is common in the elderly, especially if they are abandoned. Lack of social care and support can predispose them to undernutrition. I also want to invite clinical microbiologists. This patient has been on admission from another hospital. The days of admission, duration of admission was not specified, but I want to invite a clinical microbiologist to address possibility of nosocomial infection and the risk of multi-drug resistance in this, and to envisage and address multi-drug resistance in this patient. I will also involve physiotherapists for geriatric rehabilitation, especially for patients that are already having musculoskeletal problems, such as osteoarthritis and osteoporosis. Mental health physician and clinical psychologist. Elderly patients are prone to depression, their social isolation, and abandonment by family members. So I also want to involve clinical psychology and mental physician for psychotherapy for possible background depression. I want to involve social workers to investigate the living condition of this patient and make recommendation for geriatric care giver support. Then I will also invite other subspecialty as the need arises. What will you do when your friend came to say hello to you? I will informally discuss the patient with my friend and colleague, seek his or her expert opinion on this case as a geriatrician. I will also discuss with him or her on the need for a formal invitation or consultation of a geriatric team to review and involve and co-manage this patient with us officially. I will appreciate his or her effort and her input on this patient and keep her updated on the case. That's the question. I don't have much time now, but contribution of caregiver for the elderly, the age, UN says United Nations says from 60 in the Western world, age 65 and above, where in Africa, according to WHO 2013, the current age of 50 to 65 was agreed on. About 30 to 40% of medical admission in southern Nigeria are elderly patients. In geriatrics, a situation of diminished homeostatic reserve capacity of all organ system called homeostenosis. Geriatrics is not usually associated with symptoms in the absence of disease. If there is no disease, then there will be no symptoms. And these are some of the physiological changes that take place in geriatric patients. The blood-brain barrier is less efficient and there are risks of the meningitis. There's alteration in the function of the autoimmune system, which uh, lead to the risk of urinary incontinence, risk of orthostatic hypotension, and erectile dysfunctions. There are other listed on the slide uh, for further consultation. Thank you very much.
Wow, thank you so much, Chief, for that beautiful presentation. Thank you so much. Okay, so now we'll take comments and questions, first from the participants and then from our teachers. And let's keep the thanks coming on the chat. Let's keep the thanks coming. Okay, so there's some hands up already. Okay, I think we can take the comments first before we go to the chat. Okay, Dr. Mamadou, please go ahead.
Good morning, our facilitators and colleagues. Good morning, presenter. Thank you so much for the presentation. Just have some few questions and some comments. One, as part of the problems for this patient, would it be nice to add frailty? Frailty as a common term for most especially this elderly. Then two, multimorbidity, because as you can see, this patient has various ailments or comorbidities. So I think it would be right to use their terminologies, multimorbidity. Then one of the things that we know about elderly care is the fact that when you see them keep presenting in the hospital, there might be some form of elderly neglect or some, at worst case, elderly abuse. So as part of that, your team, in terms of all those social parts, you have to actually look into if this elderly is neglected. And typically it's when an adult who is responsible for that particular elderly does not meet or fails to meet the medical, social, or psychological need of the other adults. Then also, too, some decisions, too, that might be taken, maybe for elderly infantilization, whereby their decisions maybe might not be taken, should also be looked into play, because some have some of those interplay that can even make them even more depressed, or in terms of their depression, when they are not made to make their own decisions where they feel it's necessary. Thank you.
Thank you so much, Dr. Mamadou. Dr. Abite, do you want to react?
Thank you very much, Dr. Mamadou, for the addition. I will include all your points that are not on the presentation. Thank you.
All right, thank you so much. Okay, Dr. Sani, please go ahead.
Thank you very much, Dr. Abite, for the presentation. Nice one. Geriatrics is always challenging, but full of nice things. I just have 2 or 3 comments. The first one is, if you mention multidisciplinary, if you mention infectious disease, you don't need to mention clinical microbiologist. In fact, if you leave the shores of Africa and go to Europe or Americas, you may not hear infectious disease specialists. They're usually clinical microbiologists. So I think to avoid conflict of interest, in our facility where we stay, if you invite clinical microbiologists, you don't need to call infectious disease. Actually, they do the same role, because in short, it's just terminology change. Many countries don't say infectious disease, they say clinical microbiology. Many people say clinical microbiology without naming it infectious disease. So that's the first comment. The second comment is, as you are going through the problems, I think it's important to mention the geriatric giants. Very important, because by the time you mention the geriatric giant, virtually the patient has all of them: instability, impairment in cognition, incontinence, immobility, and rest. So those 5 things, by the time you go through them, you realize that the patient has virtually everything. So that is why he is at risk. Don't forget about pain management of osteoarthritis, because pain is one of the major triggers of even delirium and even worsening condition in them. Dehydration as well. The fact that the patient came from a nursing home or from a care home to SR is a risk. also for having complicated UTI or hostile acquired infection. So you also have to mention that as a trigger, very important. Then last is you shouldn't forget about nutrition. Nutrition is very important, especially in elderly patients, because the neglect and the
Steve, I could barely hear you. I'm not sure if it's my network.
Yeah, I can barely hear you. Dr. Sani, we can barely hear you.
So sorry, it's my network. Network is not good. So those are important comments I made. I think that's all.
Wow, thank you so much, Dr. Sani. Thank you so much. Dr. Florence, please go ahead.
Okay, good morning, facilitators, senior colleagues and colleagues. Okay, the previous speakers have actually said everything. You actually did an excellent job. Just a little add-on to the team and the team to be added to the management. The family support team should be added. Why? Because they need to provide money. There could be lack of funds, you understand? Because these elderly patients actually shows some form of neglect from the history of recurrent infections, poor feeding, and then recurrent falls. So the family support team would really be very necessary to be added to the team of management, maybe in the aspect of provision of funds, in the aspect of making sure healthcare givers are around to take care of them if they can't do so. So family support team would be very essential. Thank you very much. That's just what I have to say.
Thank you so much. Okay, I think we should take from our chief. One success. Okay, before I go to the chat. This hand is already up. Ma, please go ahead. Hello.
Hello, good morning.
Good morning.
Dr. Robert, did you call me?
Yes, ma.
Okay, thank you.
Do I take the chat first before you come up?
Okay, good morning, facilitators. Good morning, participants. Chief Christabel, I don't know if I can talk now because the other day you said it was not time for me to talk. Okay,
Should I comment on the chat first?
Okay, success. You're a facilitator now. So when Dr. Kele say facilitators, they have comment, a big girl to then anything that is more specific that talk about, we wait till the end of the meeting. Yeah.
All right. Thank you, Ma. Let me take the comments on the chat first before you come in, Ma. That's a success. Okay, so on the chats, a lot of thanks for you, Dr. Ebitoye. Dr. Yahaya is saying thank you for the good presentation. Dr. Blessing, thank you. That was a wonderful presentation. Dr. Raleigh says thank you. Dr. Becky, thank you, sir. Dr. Amodu Bosede, thank you for the lucid presentation, Dr. Ebitoye. Dr. Mustafa says thank you. Dr. Amakri Binabo, Dr. Shamsuddin, Dr. Olajumoke Ojimi is saying thank you for the wonderful presentation. I think the urologists can also have an input as part of the multidisciplinary approach. Dr. Adebimpe is saying excellent presentation. Dr. Ebitoye, acute pain management for the osteoarthritis is important. Okay, Dr. Sani mentioned that. Then sleep disorders should also be addressed. Okay, so maybe you need the pulmonologist, the sleep specialist. Dr. Rita says, thank you for the presentation. Another problem that the elderly face is polypharmacy. Dr. Regina is saying, thank you. Dr. Momodu, thank you so much. Dr. Okura for medical, thank you, says, thank you. Dr. Wasinda Francis says, thank you for an excellent presentation. Can a problem with polypharmacy be added in view of the comorbidities? Okay, thank you so much. Someone also mentioned it earlier. Dr. Irabo Tom says, instability, immobility, iatrogenesis, impaired cognition, and incontinence. Those are the geriatric giants. Thank you so much. Dr. Mohammed is saying the 5 M's too. Chief, maybe you help us and outline the 5 M's. Okay. Dr. Jamila says, thank you for the wonderful presentation. I think we should add hypopituitarism to our list of problems of the patient. She presented with GI symptoms, UTI, hyponatremia, and hypoglycemia. We should therefore evaluate the pituitary and treat as appropriate. Thank you so much, Dr. Jamila. Dr. Akinomi says, particularly hypoadrenalism, low glucose, and then hyponatremia. And Dr. Rita Wakama is saying, thank you for the wonderful presentation. Okay. So Dr. Bito, I don't know if you want to react to any of these. If not, then we'll take our teachers. Okay, Dr. Shamsuddin.
Okay, thank you. Yeah, thank you. Good morning, my teachers and colleagues. So I just want to make some comments regarding some of the issues raised. Regarding the frailty, there are a number of frailty scoring systems that one can use to assess an older adult as per frailty. But the easiest and the commonest one that is used is what we call Rockwood Clinical Frailty Index. That assesses the frailty using like deficit that the individual older adult has. It uses more of activities of daily living that include like ability of an older adult to take bath themselves, to eat, to feed themselves, to maybe to transfer, say maybe from bed to chair. So all those are called activities of daily living and instrumental activities of daily living. And that includes things that are a bit higher, like driving, managing finances, using telephone, and so many of them. So you now use these activities to rank the older adult on a scale of 1 to 9, with 1 being robust. That is, the older adult is robust. He can even do things that are that people that are younger than his age could do, to 9, which is terminally ill, in which the patient is undergoing palliative or hospice care. That means like they have less than 6 months to end of their life. So in between them, there are a number of values based on the activities of daily living, based on the number of comorbidities that the older individual has. So this is this. While the presenter uses acute confusional state, so but in geriatrics, the terms that is more preferred is actually delirium. You use delirium instead of acute confusional state because the acute confusional state is more of a vague term that is not accepted. For this patient, he has listed almost all of the problems that the patient has. But in clinical practice, it's important to know that delirium can be caused by a number of things. Most of these things that the patient has contribute to the delirium that the patient has. So that means you may need to address the UTI, the hyponatremia, the hypoglycemia, the pain from the osteoarthritis that the patient has, and so many other things that the patient has that might contribute to the delirium. My last comment is on the 5 M's that was mentioned. He has already written them. Mind, that one of the M is mind. That means the patient has dementia, depression, or delirium. The other M is mobility. We look at ability of the older adult to move. Do they use walking aid? Do they have any mobility challenge? Then the next M is multi-complexity. Most older adults, they have multiple problems, ranging from social, from medical, social, psychosocial, and so many of them. So you may need to address all of those things. The next M is medication. We talk about polypharmacy and their ability to react to medications. That means you may need to be careful on the drugs, and drug interaction is very high in them. So that is the the medication there. The last one is matters most. In older people, you don't tend to pay attention to what you feel is okay for them, but you should ask of what is most important to them. For example, if an older adult is having, let's say, acute coronary syndrome, for you may be more concerned about the morbidity and mortality that is attached to the condition. But for the older adult, what is more concerned with is the pain. So you should try to address the pain and all that. More so, he may even have an acute coronary event without any pain. So probably he may have a pain on his knee that is more worrisome to him. So we tend to pay more attention to what matters most to the person, rather than notwithstanding, without neglecting the things that are important in providing care for the older individuals. And these are my contributions. Thank you very much.
Oh, thank you so much, Dr. Shamsuddin, for that wonderful perspective. Okay, so lastly on the chart, thank you, Dr. Mamodu. He has listed out the 5 M's, and then Dr. Adibuka says, wonderful presentation. You may need a gastroenterologist to help you manage the poor feeding with possible PEG tube for feeding if there is dysphagia, and an investigation for insulinoma because of the hypoglycemia. And Dr. Ode is saying, thank you so much. You may also need a neurologist. Okay, so now we'll take comments from our teachers. Okay, Mark Isabel.
Dr. Success.
Hello, good morning. Thank you so much. Maybe because Pimpe saw that they have called me, she now called neurologist. Thank you so much, President. I really appreciate the 5 giants in geriatric management. But then again, the neurologist in this case cannot be overemphasized. I will give you an instance. There was a patient that we managed. I was just new to the senior residency program. And then there was this elderly woman that came with acute confusional state. The team that managed before, that gave us the consult, the diagnosis was acute confusional state in the elderly. However, they had requested for a CT scan. I was like, why would they request for a CT scan when this is just acute confusional state? But when the CT scan came out, it was bilateral gangrene, in fact. Unfortunately, we lost that patient. And so for every patient, for us in our department, in our unit, and then in our department, for every patient that presents with acute confusion, whether you are suspecting a stroke or anything, as far as there is altered sensorium, please do a brain CT scan. And then it's important to involve a neurologist in this patient, because this patient has hypoglycemia, which we can see in the neurology, a stroke as a complication, and then metabolic derangement, including all the other symptoms I was said. Thank you so much. It was a very enlightening presentation. Thank you.
Thank you, Dr. Success. Thank you so much. Thank you. Dr. Ibitoye, thank you for your presentation. I must commend the class. I love this particular set of participants. When we say please, when we usually request for something, and it's good to know that you guys listen to our appeal. See how everybody is just contributing. Thank you, Dr. Shamsuddin, Dr. Muhammadu, and Dr. Momodu. I don't think I got all the names, people that were asking really wonderful questions, people that were commenting. We appreciate you all. Dr. Kalamama, thank you. Please, we want to be hearing your voices. Yeah, thank you so much. Most of you are specialists in your right already. That's the truth. It's just a matter of months, matter of weeks for some people already, and you just get the certificate. So we want to hear you speak. We want to hear you talk. If there's any issue with the way you speak, and so can you phrase this way? Can you phrase that way? But everybody that has spoken this morning spoke quite eloquently. Please, We know we have people with stuff here, so we want to be hearing them. Please speak. We all are here to learn, really. The facilitators, a lot of things we can learn from the participants, really. Is a mutual relationship. So thank you. I don't know if Chief Chitu, Chief Banse, Cookie, Remigus, Okopi, Fatima. I know I said Abdullahi. I don't know if you have any comment. Okute, Yahaya, Mohammed. If you have any comments.
No, ma. Thank you. I don't have any comments.
Okay.
I think we can go ahead.
That's good. So, Dr. Ekele, thank you so much. Dr. Bitre, once again, we appreciate you. Thank you. It was a lucid presentation. Thank you. Dr. Ekele, to the next presenter.
All right, thank you, ma. Okay, Dr. Henry. Dr. Henry, please, can you share your screen? Unmute yourself, you're muted.
Okay, am I audible? Good morning, everyone. Good morning, everyone. Okay,
Good morning.
my screen is being shared. Is sharing.
Yeah, we can see it, but it's not on slideshow. Okay. Is it possible to put it on slideshow?
Okay, good morning, everyone. So I'll be taking question 1B of April 2023 recall. So this is a picture of a child with staphylococcal scalded skin syndrome. And the question A, what is another name for this condition? B, what is the pathophysiology? C, what are the histological findings? And D, list 3 differential diagnoses. And E, is there any oral involvement? What is the other name for this condition? Staphylococcal scalded syndrome is also known as Ritter's disease or Ritter's skin disease in newborn, named after Gottfried Ritter, who published case series years ago. And it's also known as staphylococcal epidermal necrolysis. The pathophysiology of staphylococcal scalded skin syndrome, only about less than 5% of the strains of Staphylococcus aureus can produce the exotoxins that can cause this skin condition. And it's a class of serine protease exotoxins. There are 2 major types, the exotoxin A and the exotoxin B. It's also referred to as the epidermolytic toxins. And they are usually heat stable and resistant to proteases and acidic pH, allowing them to survive harsh environments and cause damage to the skin. There are other isoforms that are found that are observed in other animal models. The exotoxin A and B are encoded by the genes carried on the Staphylococcus aureus bacteriophage for exotoxin A, and also the Staphylococcus plasmid for exotoxin B. So these toxin genes can integrate into the bacterial chromosomes and then transfer the genes between bacteria. So, and they're usually released following expressions of genes locally by the staphylococci. So usually there's usually a local infection via which these toxins will travel via hematogenous spread and then concentrate in the stratum granulosum layer of the epidermis. And these toxins are produced during the post-exponential phase or the log phase of the bacterial growth as inactive precursor molecules. So they still need to be acted on by the bacterial protease of the Staphylococcus aureus to become active. So when they're like the aureolysine and the staphopen A, when they act on them, they activate them. And once they're activated, the toxins bind to and cleave to the desmoglein 1 protein. So the cleavage of this desmoglein 1 protein will result in the detachment of the epidermis and, of course, give rise to the characteristic blistering that we see in the staphylococcal scalded skin syndrome. And the mucosa membranes or the mucosa are usually not involved in the staphylococcal scalded skin syndrome. What are the histological findings? The histological findings on biopsy are characterized by the intraepidermal subcorneal cleavage with the splitting that occurs beneath the stratum granulosum and also within the stratum granulosum. And this cleavage space may contain free-floating or partially attached acantholytic cells. Then the other parts of the layers of the epidermis are not remarkable, just this stratum granulosum and that is affected. Then the dermis has no inflammatory cells or bacteria, as seen in this diagram. You can see the splitting of the stratum granulosum layer, and there's no infiltration of any inflammatory cell there because it's just the toxin that is involved. These three differential diagnoses. The first is the bullous impetigo. Usually this one is more localized. So unlike the staphylococcal scalded skin syndrome, that is more widespread. And usually the contents or the content material of the bullae usually have the implicating organism of the Staphylococcus aureus. Another differential is the toxic epidermal necrolysis, which is more severe. And this one involves the whole layers of the epidermis as against the Staphylococcus scalded skin syndrome that involves only the stratum granulosum of the epidermis. Then another differential is the pemphigus vulgaris. This one involves more of the, it's an autoimmune blistering condition due to the immunoglobulin G from the beta cells that are produced. Then is there any oral involvement? For the Staphylococcus scalded skin syndrome, the mucosa are not involved. It's only limited to the skin, not the mucosa. I'll use this outline. This is a diagram showing the layers of the skin, the epidermis, and of course the dermis, and the other adjoining structures. By way of introduction, the staphylococcal scalded skin syndrome is also known as the Ritter's disease, and it's an uncommon superficial blistering skin condition that is characterized by widespread erythema and exfoliation, and is caused by the exfoliative toxins produced by the bacterium Staphylococcus aureus. And the severity varies from few blisters to severe exfoliation, affecting almost the entire body. It's most common in children and neonates and rarer in adults, but if it does occur in adults, it's severe. And there are conditions that predispose adults to having this severity, which we'll talk about later. It has also been described in adults with renal impairments, immunologic deficiency, and other chronic illnesses, like maybe chronic kidney disease. And the overall incidence is higher in developing countries, and wherever the incidence of staphylococcal infection is higher. It's also more common in warmer climates, and it is more frequently reported during the summer months, with a mean annual incidence approximated at 7.67 per million US children, with 45.1 cases per million US infants aged less than 2. For the pathophysiology, it involves a number of factors. As I've said earlier, that it's estimated that it's only less than 5% of all the strains of the Staph aureus that produce the exotoxins that can cause this condition. And the toxin is a class of a serum protease exotoxin. And there are two major types, like we said earlier, the exotoxin A and the exotoxin B. And it's also referred to as the epidermolytic toxins or the exfoliatins. Now, these toxins are heat stable and they are resistant to proteases and acidic pH environments. And this allows them to survive harsh environments and, of course, cause damage to the skin. Like I've said earlier, that they are encoded in genes and they carried on the bacterium on the bacteriophage of the Staph aureus and the plasmid for the exotoxin A and exotoxin B for the plasmid. And these toxins can be integrated into the bacterial chromosomes and transfer the genes between bacteria. Now, when these toxins are released following the expressions of the genes locally by staphylococci, the toxins travels via hematogenous spread and then concentrates in the stratum granulosum layer of the epidermis, where they now cause the detaching of that layer of the stratum granulosum, and they are produced during the post-exponential phase of the bacterial growth as inactive precursor molecules. And when acted on by the aerolysine and staphopain A of the Staphylococcus aureus proteases, they are now activated and they cause this separation in the stratum granulosum. The severity of the staphylococcal scalded skin syndrome is influenced by various factors, like the amount and the type of the exotoxins that is produced, and the patient's immune response, and of course,
you have 1 more minute.
Okay, ma'am. For clinical presentation, there's usually a prodromal localized Staph aureus infection of the skin, which usually most times may be unnoticed. And the infection is often not apparent before the staphylococcal scalded skin syndrome rash begins to appear. They're usually preceded by generalized malaise, fever, and irritability, which most times may not overtly appear unwell. On physical examination, the patient will be febrile. They may have conjunctivitis. They may have perioral crusting and spread of the mucous membrane. They may be dehydrated. Then there will be positive Nikolsky scan demonstrated, and there will be diffuse erythematous rash, often beginning centrally, and then coalescing to form the bullae, which are flaccid and ill-defined. And the exfoliation of the rash, which may be patchy or sheet-like in nature, is also noted. Then for the differential diagnosis for the bullous impetigo, We also see the demonstration of the Nikorsky sign that is positive. But however, this is usually localized to the site of the infection, so that the content of the content of the bulle will isolate the Staphylococcus aureus strain. Then for the Pemphigus vulgaris is just we will not isolate the Staphylococcus aureus strain. Then for investigations, routine investigations like the full blood count and differentials, which will elicit leukocytosis, and of course the neutrophils will be elevated because of the presence of the Staphylococcus in the bloodstream. The ESR will be elevated. For the E and U, because of dehydration, there may be presence of electrolyte derangements, which will be corrected. Then for the blood culture, if there's an underlying sepsis, we want to isolate the organism for proper antibiotics administration. Then for the gram stain or culture from the local infection sites, we want to take a swab from the secretion and then do a gram stain and then culture to isolate the organism. But most times for the Staphylococcus scalded skin syndrome, no organism will be isolated except the local site of infection is identified. Then we can take a swab from there. Then the skin biopsy will show the characteristic histologic picture that I described earlier. All forms of the Staphylococcus scalded skin syndromes are characterized by intraepidermal subcorneal cleavage with splitting that occurs beneath and within the stratum granulosum. The cleavage space may contain the free-floating or partially attached acantholytic cells, and the remainder of the epidermis appears unremarkable, nothing is really found there. And the dermis also contains no inflammatory cells or bacteria. Then the management of this involves a multidisciplinary approach. If it's for a child, then they will need for the pediatrician to come in. Then for the dermatologist too, also we need dermatologists to come in because of the loss of function of the skin. And also the infectious disease specialists to also come in because of they are not predisposed to infection and culturing any secondary infection and appropriate treatments to be given. Therefore, the plastic surgeons, of course, because of for some severe cases, they may need dressing, and of course, the plastic surgeons will have to get to minimize the scarring that can follow after healing. And the treatment consists of supportive care, like for the electrolyte derangements, it needs to be corrected, and to prevent perennial AKI also, and to eradicate the primary source of infection. Then the intravenous fluid, of course, for rehydration. Then parenteral antibiotics. Prompt treatment with parenteral antibiotics for anti-staphylococcal antibiotics is essential, as most of the staphylococcal infections implicated for the staphylococcal scalded skin syndromes have penicillinase and are resistant to penicillins. So the penicillins resistant synthetic penicillins, such as the nafcillin or the oxacillin, should be started promptly. Then the areas where we have the medicine resistant Staph aureus prevalence, we want to use the vancomycin. Then, of course, there's also place for adjunct therapy, like the topical therapies, like using the mupirocin cream. Then patients who may have the severe form of the disease may require to be nursed in the ICU or in the bones unit care. Steroids are not indicated because they may worsen the immune function. And NSAIDs and other agents that potentially affect the renal function should also be avoided. Therefore, prevention, hygiene is key. Adhering to good hygiene practice, which include proper and frequent hand hygiene, then avoid sharing of items such as towels and clothes, then keeping the nails short and clean, then using clean and dry beddings and clothing, and to keep the wound and cuts clean and covered is also key in preventing this. Then preventing contact with infected individuals in child care centers too and school is also important, as there could be some asymptomatic carriers who can predispose to an epidemic in such child care centers. Complications include dehydration, of course, from the loss of function of the skin. So the insensible loss is also increased. Then from shock also, both from the underlying sepsis and also from the dehydration. Then AKI also from the dehydration too, and also from the sepsis, and hypothermia from the loss of function of the skin to regulate temperature then sepsis because of the loss of mechanical barrier of the skin, then ability to death. Then for the prognosis in children, it's usually excellent with complete healing within 10 days. But the prognosis in adult depends on the host immune status, as they already have some compromised condition, maybe like a chronic kidney disease, immunosuppression, and it carries a significant rate of morbidity and mortality in adults. These are my references. Thank you.
Thank you so much, Dr. Henry, for that beautiful presentation. It was nice and detailed. Okay, so now we take comments and questions first from the participants. Okay, there's already a hand up. Okay, maybe we'll take the comments on the chat first. Okay, let me just make my own comments, just to add a little to the differentials. I think cellulitis can also be a differential, impetigo, toxic shock syndrome, even SJS, Stevens-Johnson syndrome, and then maybe contact hepatitis and chemical bonds could also be differentials. And sorry, I don't know whether you mentioned it as part of the pathophysiology. While it's more common in children, I think they're not able to effectively clear the toxin. Okay, so that's my add-on. Okay, so Dr. Florence, you can go ahead if I take the comments on the chat.
Okay, thank you so much for that beautiful presentation. Okay, just to add on to the differential diagnosis, we also have the pemphigoid foliaceous. You know, that actually presents the same way with the SSS. Okay, so but what differentiates it from that is that in this case, there's acantholysis, meaning that there's loss of cohesion of the keratinocytes. So they still present with that subcorneal blistering, but at this point in time, there's acantholysis in this case. So they present in the same way, and what is affected here also is the desmoglein 1. Then for pemphigus and vulgaris, as you mentioned, it's actually an autoimmune disease affecting the desmoglein 3. So desmoglein 3 can be found in the mucosa. So in pemphigus vulgaris, there's mucosal involvement because of the desmoglein 3 that is affected. You know, the reason why the mucosa is not affected in SSS is because what is affected is desmoglein 1, and desmoglein 1 is just restrained to the epidermis, not affecting the mucosa. So that's just like an add-on for what I have to say, that pemphigoid foliaceous can actually be added to it. Thank you so much.
Thank you so much.
And then also dermatitis herpetiformis is also a differential here as well. Thank you.
Thank you so much, Dr. Florence, for that beautiful addition. Okay, so let me take the comments on the chat from Dr. Mamodu Jafaru. Says, thank you so much for the presentation. His comments, the toxins are serine protease targeted at desmoglein 1, which functions in cell-to-cell adherence. Thank you. The separation is intraepidermal between the spinosum and the granulosome. Thus, you can have Nikolsky sign positive. And then questions, why does SSS not affect the mouth? And then where do you find desmoglein 1 and 3? And then does any one compensate for the other? Then what is Asbo-Hansen sign? Okay, Dr. Henry, do you want to react to that?
Okay, Chief already explained to me in her comments when she talked about why it's not affecting the oral mucosa because of the desmoglein 1 that is not distributed there, while desmoglein 3 is distributed there. So that's why the spread will not involve the oral mucosa.
All right.
So that's what I understand.
Or the Asbo-Hansen sign?
I'm not sure about that now.
Okay. I think someone can just help us check it up. All right. So Dr. Regina, okay, Chief, go ahead. Dr. Linda wants to help us with that. Please go ahead.
Good morning, facilitators and colleagues. Thank you, presenter. Asbo-Hansen sign is when you apply direct pressure on the blister, and then there's spreading of the blister into, like, you understand, the surrounding skin. That's Asbo-Hansen sign. And this is positive in like bullous diseases. But Nikolsky sign is when there's sharing pressure laterally, like laterally to the, that's by the side of the lesion. You put a sharing pressure, and then there's extension of the content of, or formation of another blister where you put that pressure. That's Nikolsky sign, and that is present in the pemphigus diseases. So more of intraepidermal lesions rather than the, yes, the epidermal rather than the subepidermal. And Dr. Kalamama, it is pemphigus foliaceus, not pemphigoid. I know it can
Thank you.
be called. Thank you. And also in your differentials, you said bullous impetigo is just very localized. That can actually, not in all cases, it can actually also be widespread. So just ignore that.
Thank you.
Oh, thank you so much, Dr. Linda, for that add-on, for the clarification. All right, so let me continue with the chat. Okay, so Dr. Regina says, thank you. Dr. Owa Shoaibu says, thank you so much. Dr. Musa Joseph says, thanks for the lucid presentation. Dr. Sori Conte, thank you for a comprehensive presentation. Dr. Rita Lako says, thank you for the presentation. Dr. Cassidy Ibi, okay, Dr. Linda, she has already made the comments. Pemphigus spoilaceous, not pemphigoid. Okay. All right. Dr. Owal is also, the dermatologist are out. Okay, Dr. Yaya Mohammed says epidermolysis bullosa cystica could also be a differential. Thank you for the good presentation. Dr. Onelumneka says thank you, and Dr. Okora for Maduka says thank you so much. Thank you so much, Dr. Henry, for the beautiful presentation. Okay, I can't see any other electronic hands up, so I think I'll hand over to our teachers right now. Marcus,
Thank you. Thank you. I was even about drawing your attention to the time. I want us to finish 8 on the dot so that people can go for their normal daily activities. You know, most doctors, especially those in training, are usually in the hospital before 8 for morning review and morning meetings by 8 on the dot. So we want some of these our guys to be going late for meetings. We really preach discipline, so it's not encouraging. So going forward, Dr. Keller, you help us to streamline I know you, I trust you, and you know how to organize that. So thank you so much, everyone. The presenter, Dr. Henry, did well, was quite a lucid presentation. And I most appreciate the dermatologists. This is what we preach. And as I said earlier, when we make an appeal, is good, and we're excited to know that our appeal is granted. So I must appreciate the dermatologist, Dr. Linda, for coming to our rescue. So the facilitators do not need to speak. This class, even though we are consultants here, is still participant driven. We want to be speaking, we want to be contributing. And Dr. Ekele, they don't like checking up with when you are specialists, stuffy people. So it's just for us to, just one of the facilitator to, the participants just come in. We have a lot of people here, and a lot of them, I know their personality, they have a lot of stuff. That's why sometimes I'm amazed the house is quiet, because some of these guys are stuffy. They have a lot of stuff. They don't know what to do with that stuff. So please, I'm glad you guys are speaking up. I want to encourage more of such active participation. I don't know if the presenter, what I would just say is that your management, please try to be more, you are a little theoretical. What we always advise is, once you're doing a specialist topic in the management, try to go straight to the point, then try to be as real as possible, because sometimes you may be asked, oh, is this what you do in your facility? And you know, most of these examinations is people in charge are specialists. So it will make sense if you are real. So you are quite theoretical. So because of time, I don't know. So for the management, we talk about drug management, pharmacological and non-pharmacological. So the non-pharmacological, we talk about feeding, weighing your patient daily, feed management and all, because AKI can, depending on the extent of the area involved, especially if it's a child, you know, you don't have so much surface area to start with. So the So you need to monitor them better than even an adult, because so you need to monitor that input output, and we need to weigh them daily to help you. Then protein management, you need high protein of high biological value. Usually encourage animal protein. Encourage animal protein. Then for the pharmacological, that's where we talk about the mupirocin cream, and if need be, systemic antibiotics. Most time we already do systemic antibiotics. We just do topicals. Therefore, the other things we do is really, really good moisturizers to lock the moisture in. You know, the skin is it's like a protective barrier, so it minimizes water loss. So you need something to act like protect the patient. Then we'll talk about double barrier nursing. Somebody told me that there's a new name for it. I can't remember the new name, but double barrier nursing, minimize touching the patient, protect the patient, and protect yourself so that you don't spread infection only to secondary bacteria or fungal or viral infection. So you protect the patient. And such patients should be managed in, I think the presenter did well on that particular area where patients should be managed. They are usually managed like burns patients generally. So you mentioned that, which was quite wonderful. I think other comments really have been said. So, but the presenter overall, you did wonderfully well. You did wonderfully well. Want to encourage you to speak more. You speak quite nicely. So please, we want to be hearing your voices. Please, Dr. Henry, please, want to be hearing your voice, please. Thank you. Thank you. This, I don't know your subspecialty. Please, what's your subspecialty again?
Cardiology.
Okay, please. So want to be hearing your voice, please. Thank you so much. Once again, we appreciate you. I don't know if any of our chiefs, Chief Bansi, Chief Cookie, Chitu, Amigos, Fatima, Kopi, I don't know if any comments or to success. Abdullahi, we now have wonderful facilitators. Principal should pass joining the facilitator team, so the list will be endless. So Dr. Yahaya, Dr. Okute, any comments, please? Dr. Fatima, any comments? So thank you, everyone. You see, the presenters, the participation was top notch. See, we with the facilitators, you guys have left us speechless, which is what we love to see. So thank you, thank you, thank you.